Okay, so I have got Shriti Pattani with me, and I am delighted to have you here. You're a national clinical health expert for NHS England, but like all of us, you have many different roles and many different hats. So just tell us a little bit more about perhaps your broader roles and also why you're here today at the water cooler.
Thank you, Ben, for having me. So my background is occupational health and general practice actually, and public health. And so apart from being the national clinical expert in occupational health and wellbeing for NHS England, I actually run a service, an occupational health and wellbeing service in North West London for a large acute trust as the head of service for them, which I've been doing for a very long time now, about 25 years. So it's quite nice to actually be able to combine an operational role with a strategic role. And I think the key for me here is that I take back what I learn on the front line back to NHS England, and it works really well. So they're my two main jobs.
Which is great, because of course that's not always the case, is it, with strategic roles, not just in the NHS really, but anywhere. Anywhere.
And I think COVID changed that. So it's been interesting. The directorate I work in, which is the workforce team, did not have a clinical person in their directorate until COVID. And during COVID, I was chair of something called the NHS Health at Work Network, which is a membership organisation of NHS OH services. So of the 132 NHS OH services in England, 129 are members. So it's a really wide reach. And as a result, NHSE reached out to me and said, actually, we don't have this expertise. And, can you help? And of course, we were all trying to do what we could to help. So that's where I started working with them. And then as they started to understand what a clinician could bring, they actually created a role for a clinician, a part-time role, so that they can get the insights into actually what is going on the ground. So hopefully some of the things that we have been doing, so one of them is we launched a 5-year strategy called Occupational Health and Wellbeing Together Strategy, which is now in its 3rd year.
That nationally?
That's nationally, and that has quite a lot of information that's practical and doable on the ground with minimal investment. And some of that has come absolutely from the fact that actually we're getting feedback from the ground. And of course, I haven't been the only clinician involved in that. You've got other colleagues like Dame Carol Black and Steve Borman and other colleagues who've been involved in an expert advisory capacity. But I've been actually part of the NHSE team. So that's a hat that I very much value, and hope that I can influence direction of travel where staff health and wellbeing is concerned in the NHS. But separately, just to make it more complete, I've been doing some global work with the global team at the Department of Health through a programme called Health Systems Connect. And that's really about supporting health services in countries where we recruit a lot of healthcare workers from. And that feels actually very comfortable to me that we're giving something back and supporting healthcare workers, where we're actually bringing quite a few of them over here.
Is that a post-COVID thing, or does that date back to before?
Yeah, so there was some work going on before COVID, but certainly since COVID, it's become much more interesting, particularly in Africa, and that's obviously because they have the same challenges that we do around workforce. And COVID was what actually led us all to acknowledge that the NHS workforce were an important driver to deliver patient care. And I think that was recognised in the private sector for many years, but perhaps we focused so much on patient care and safety that we forgot that actually, the people who deliver it need to equally be looked after to deliver that safe care.
Absolutely. And it's it's interesting that I wasn't aware of that, and that scheme, and I think it probably would go to, I don't know, it's all kind of amalgamated, but like people's views of where how both the health service but more generally services are populated with workers and where they're coming from now compared with, say, 10 years ago. I think that the fact that scheme exists would surprise a lot of people, perhaps. Like it's not that out there.
No, but actually what is amazing is that we've got diaspora from those countries who are taking their annual leave time from the NHS to go back to their countries of birth to give back. And I've been absolutely overwhelmed by what our diaspora are doing. So to be able to support them, and of course they know the culture, so it's good to be able to support them to deliver some of what's needed, and some of it is actually relatively straightforward. So for example, in some areas, so the areas we're working in, Ghana, Kenya, Uganda and Nigeria, is actually let's train up people to do risk assessments within the workplace. Not patient risk assessments, but staff risk assessments. So we're actually looking after the physical health, and I think psychological health is quite complex, but certainly in terms of physical health, there are things and steps that we can easily share that they can adopt. And again, it's not rocket science, but it's not necessarily been high on the agenda, but it is now. And why not share resources? And
Definitely.
And equally, I remember when I went out to Ghana last year and spent some time in one of the government hospitals, that they've got some really good systems in place for their junior doctors. And I was able to learn from there and bring that
Goes both
back.
ways,
And again, because they're often working with staffing levels that are a lot smaller than the staffing levels we have, they have overcome some of those challenges or managed some of those challenges that we are trying to.
It's not the too hard to do pile, if you like, because of the scale.
Yeah, absolutely.
So it's interesting. I mean, I guess I did a really interesting conversation in this yesterday with the culture director of Yelp, so over from San Francisco, and she was talking about a piece they've done on storytelling, and they'd really actually, it started off as a bit of an experiment, but ended up being really culturally central to how they're managing a globally remote workforce. But how they did it was fascinating. But it occurs to me, listening to you there's some amazing stories that must have come out of this initiative. And are those stories being told in the NHS? Is that something that's kind of being shared and is it becoming a thing?
Yes. So a lot more so. So we had in March this year the UK Africa Health Summit, and the Global Health Partnership, they used to be called FET, but they're now Global Health Partnership, and they are a charity that's funded by the Department of Health and Social Care. And they do a lot of work to support healthcare workers in other countries, particularly Africa. And having these health summits actually allows people to share what they're doing and across the board, learn from each other, but also taking them back to their own organisations, because a lot of them are current NHS workers. And I think certainly in so in my organisation, so at London North West Hospitals Trust, we have something called the International Staff Support Network.
Yeah.
So we share some of these stories about what's happening, what people are doing. And actually, it's incredible when you start having these conversations, what people are generously giving. And I think of anything, the most generous thing you can give is your time.
Yeah.
And, they're taking their annual leave, they're actually going back, they're fundraising in their own time here to be able to afford to give back, and, really spending quite a lot of their time and energy doing that. And
creates real cohesiveness, I guess, sharing those stories and respect, amongst your workforce.
But also, sort of doing the 360, which is when our diaspora community come to the UK, they have their own challenges, and that's adopting to a new system, a new sort of way of working, often feeling quite lonely having left a country and a culture they know. And so from our angle, from an occupational health and wellbeing angle, we also need to be aware of their needs. And they are increasingly a huge part of our workforce. So again, one of the things that we started was our international staff support network, and that's been hugely beneficial because we started to notice when we look at data, it's all about data-driven decision making, isn't it? That when people come from abroad to work in our NHS, nurses 3 to 6 months after they arrive, we start seeing a dip in their mental health.
Okay.
Doctors, it was longer, about a year, 18 months.
But it still happens.
And it happens, but actually doctors were much more likely to be referred to occupational health for performance issues, whereas nurses were much more likely to be referred earlier for the odd day off here and there. And actually what they just wanted to do was curl up and stay indoors because they were adjusting to a new way, a new culture. They were lonely. A lot of our diaspora don't realise that in the winter it gets dark at 4 o'clock in the afternoon.
Are you seeing that nationally, or are you talking about there inside your trust?
Well, inside our trust, but actually increasingly across the country. And so in fact, when I speak to diaspora communities, and that's the other thing that I've learned, is that the different diaspora communities do have national networks now. And they're doing some of this work so that when they know people are coming over from their country of origin, they're actually saying, look, do you know?
There's a destination,
So do you know actually these are the sort of things to expect? And we've now created a handbook with lots of acronyms in them, but also areas around London North West where they can go shopping or church or mosque or, and where they can find communities where they can be supported. And also, healthcare is delivered so differently. So often the expectation by our diaspora community is that they'll come to occupational health and they'll get the treatment they need. They don't always realise they need to register with the GP to get the support. So that there's a lot of work that's going on, which is great, but a lot more yet to do.
And it's also that thing of, often it's the partnership between the patient and the person treating them, isn't it, with it in our system. So, if you get physio referrals, you generally don't, first thing you don't get is physio. You get exercises, and it's about how you engage with that information. You've got to be able to get access to the information. You've got to take it in. You've got to understand it, and then you've got to do it.
Yes.
And there's that commitment, and that, I should think that is perhaps a bit different to what they are expecting.
So Can I share a story with you?
Please,
It
yeah.
was one of my band 5 nurses actually, who when she came over from India, she was working on an elderly care ward, and in the middle of the night, one of the patients who had dementia kept saying, "I trying to climb out of bed and, over the barriers and saying, I want to spend a penny." And she kept saying, "That's fine, you can spend your penny tomorrow. It's your money, you can spend your penny." And then, of course, he got increasingly agitated. So one of the other nurses came along and said, "Oh, that actually means he wants to go to the toilet." And she had no idea.
Yeah, and why would she?
Yeah, and actually, even those sort of things, there is an education element to things like that. That
You don't know.
Yeah, absolutely. So we have some really interesting sort of staff network meetings where people who've experienced those sort of incidences actually share, so that they can learn from each other. That actually spend a penny doesn't actually means going to the bathroom, and she just thought the patient was really agitated and wanted to go to the shops. And that was a real learning lesson for me, because it just meant some of the things we take for granted actually
Absolutely.
are, for somebody else. It's
It's this sort of, the things you've been describing kind of feel to me like a version of this, the kind of, you found a way to personalize, the occupational health approach. There's a lot made of personalization, which I sometimes think, when you see it in insurance contexts or, in marketing speak, it's actually basically just apps or persona based stuff that it doesn't really mean personalization. It's not about the person's personality or really truly understanding their needs. It often plays out as being something to draw people in and that can't be delivered on. But I think the level that you're talking about, it does feel like you're making a real concerted and sort of coordinated effort to personalize.
Well, that's nice for me to hear, but I think I see myself as being in a really lucky position. We've been an in-house service that's been supported by my organisation for a long time, and therefore, we're integrated into the organisation. So our objectives very much mirror the objectives of the organisation, and workforce obviously is a key part of that, and therefore, we are able to have a say at the board level. I need to be able to demonstrate that what we're doing is making a difference. So it's all about, evidence-based interventions, and that includes wellbeing interventions too. But also database decision making around referrals, sickness absence, accident and injuries, and so we can have a bespoke program geared towards our organisation.
Driven by the data that you...
Yes, and also, there are times when we know that the organisation's about to go through a really difficult time, just because of the changes that are coming along, and we're able to manage some of that by a proactive approach and actually start doing some work with our colleagues and our staff in advance of the change coming, so that we can actually say, look, you might feel XYZ, we're all going to feel different about this. And actually, if this happens, we're here to support you. These are the resources, but actually your team are your biggest support. So actually, how can we support you and your teams now to weather the storm that's coming? But also recognise if there is one of your colleagues who needs more than that. And I think for me, that's the most satisfying part of my job, is that we are able to influence both our health and wellbeing guardian We have a CEO that is very receptive and will actually pick up the phone to me if, she has any concerns. And also if we know just simple things like if you know that there's going to be a change in the hand wash that's being used in the organisation, bringing me in early so that we can do the risk assessments and we can put pathways in place if people get any reactions, as opposed to waiting until we've got, a bunch of staff that all go off sick because their skin's broken down and for infection control reasons they can't work. So, it's from dealing with physical hazards to chemical hazards to psychosocial hazards and doing it in a proactive, preventive way.
And have you been involved? I mean, I know you're here, it's running a bit short of time, so I wanted to really talk about, actually, you're talking today about kind of the evolving nature, aren't you, of occupational health. One of the things that I've been involved in, one of my hats on, I've been involved in some conversations with NHS facilities around and some people from various sort of expert organisations around the Hospital 2.0 and the things that they're trying, particularly the end of that for me, which is about occupier wellbeing to staff and patient, and the end of that. I mean, I guess that is a big call on how occupational health needs to evolve, isn't it? If they're going to be in a completely redesigned space that is really quite different in terms of, there's obviously massive things about patient safety in there, but also about, how the employees work in that space, which in many ways should be much better. But of course, it's a long road, right, to that kind of change. I'm just interested in how that fits with your evolving occupational health lens.
So I think it's about our leaders recognising that we need to be involved early so that we can bring the ergonomics in and we can actually bring in the knowledge that we already have about how to prevention of workplace injuries. Sometimes what I find is that in the ambition of moving things on quickly, occupational
contracts health, with builders.
Yes, indeed. Doing the practical things. Yeah. Occupational health doesn't come in until there's been a problem. Yes. And actually that's often very expensive way to manage it, whereas we can come in much earlier and start to be much more proactive and help at the design stage.
Yeah, so which is very similar to what you were saying about, having that clinical voice, isn't it? Very similar to some of the people I was talking with, air quality experts, and they were saying the same thing, is that you cannot just put this on at the end, this has to be inside it.
Yeah, absolutely.
So I wish we could go on, but we can't, unfortunately. But I've really enjoyed this, Shriti. Thank you so much for your time and for sharing so much of the insight from all of your experience with the audience here.
Great, thank you.
Thanks for listening to the podcast. This episode is brought to you by Wellhub, the corporate wellness platform transforming how companies care for their teams with a single subscription. Get an exclusive free trial using the link in the description below.